Hi everyone. This is Dr. Sudhakar, Principal, Andhra Medical College, Visakhapatnam. Welcome to the 93rd episode of our continuing medical education program on COVID-19 being conducted by Andhra Medical College, Visakhapatnam. As you're all aware that we have been holding these meetings for almost over 1.5 years now. And the beauty of this program is that we discuss the contemporary issues whenever we have certain problems, either it is acute COVID or mucormycosis or long COVID, depending on the need. We've been discussing various aspects of the COVID, and particularly we are imparting this knowledge mostly to the junior consultants as well as the postgraduates in the Department of Medicine, Pulmonology, and other departments in Andhra Medical College. I'm very glad that Dr. Sridhar Chilamuri has accepted to be the moderator today. Dr. Ram Kairam has taken a lot of pains in arranging the speakers, and he has lined up speakers for the next almost 2 months now. And I'm very glad that we have a very important speaker today, Dr. Cosmina Ziana, coming here again to share her expertise, because she has been in the infectious diseases subject. She is a specialist in infectious diseases and the director of epidemiology in the Bronx Care. And Dr. Sridhar will be formally introducing her a little later. Thank you very much, Dr. Cosmina Ziana, for coming in. It's very important at this juncture to discuss this particular problem of COVID-19 along with the other viral diseases that we are facing day in and day out, particularly in this part of the country. A lot of, now that the COVID-19 cases have come down significantly, we are facing the other viral infections also, sometimes confusing and most often it's making difficult for the physicians to manage. So we thought it would be appropriate to have a speaker like Dr. Ziana to tell us as to how to differentiate between the COVID-19 and the other viral infections, as well as how to manage them when there are coexistent infections. So with these few words, I hand over to Dr. Sridhar Chilamuri for carrying on forward. Dr. Sridhar.
Yeah, thank you, and good morning to all of you, and good evening to my colleagues here. Dr. Cosmina Ziana, it's a very special privilege to introduce her. She's been my colleague and sort of our team leader right from the very beginning as we face this epidemic. Prior to that, she's also led other infectious diseases challenges that we often face in our hospital and as infection control issues as a whole. So Dr. Ziana graduated from Karel de Villa University. It's one of the oldest universities in Eastern Europe. After that, she did a residency at Albert Einstein College of Medicine, followed by a fellowship in infectious diseases at Columbia University. She also has a master's in public health, and she worked in the Health and Hospital Corporation for nearly 10 years before she came to us. She's not only the director of epidemiology, but she also leads the antibiotic stewardship program at our hospital, constantly monitoring emerging infections and bacterial resistance, which is a major concern currently after the 2 waves that we went through. And at the same time, she has a lot of interest in arboviruses. She has written about Zika and Chikungunya in the past. She's well published, and she led our task force for COVID at our institution and continues to work with state health agencies to develop new protocols and implementation of vaccines, infection control. So her expertise is quite wide, from basic infectious disease to arboviruses, HIV, and most importantly, infection control. So we had conversations about the challenges that we began to see in the United States, where we saw patients with COVID and malaria So that led us to a discussion about the challenges India would face, which has much more challenges with arboviruses, dengue, and whatnot. So I asked her to go to review that, and then how do you manage patients who are sort of syndemics that you're going to face in India? So Cosmina, go ahead and start.
Sure. Thank you very much for the very kind introduction. It is a pleasure to be here. Thank you for inviting me. Today I'm going to talk about the intersection between COVID-19 and the arboviruses epidemics, particularly focusing on Zika, Chikungunya, and Dengue, and mostly then focusing on the interplay between dengue and COVID-19. So the slides are moving, but perhaps only this way. All right, so I would like to place this topic in the context of emerging infectious diseases, which is conceptualized as an abrupt rise of a new pathogen in a host population. This term also extends to re-emergent pathogens that have a sharp increase over a short period of time in a new geographic area. We know that 60% of emerging infectious diseases originate from animals. This includes domesticated species as well as wildlife. Recent studies have suggested that zoonotic spillover is related to the human footprint, primarily anthropogenic land conversion, habitat fragmentation, deforestation, climate change, as well as invasion of ecological wildlife niches. So now moving on to the COVID-19 pandemic. This is the most dramatic example of an emerging infectious disease in our lifetime, at least so far. It has been preceded by the H1n1 Influenza pandemic in 2000. COVID-19 pandemic is caused by the SARS coronavirus 2, which is a member of the beta coronaviruses together with SARS-1 and MERS. It was initially isolated on January 7, 2020 in China after a cluster of pneumonia noticed in Wuhan. The virus spread quickly, becoming an international public health threat, a health crisis with devastating effects. There are 250 million cases around the world reported so far and 5 million deaths. The origin of the virus has been closely related to zoonotic sources. And the recent study that was just actually submitted for publication in Nature in September, and it is available in preprint, is suggesting or found that the closest known to date relatives of the SARS coronavirus 2 are actually 3 viruses found in Rhinolophus bat, or the horseshoe bat, found in caves in Laos. This virus share a 96.8 identical genome with the SARS coronavirus and point to the natural origin of this virus. The 3 viruses identified recently have a receptor binding domain, which is very similar to the receptor binding domain of the SARS coronavirus 2, and they are actually able to infect human cells. So their discovery raises fears that there are numerous coronaviruses out there that have the potential to infect people. This slide illustrates the distribution of the coronavirus cases around the world. Most cases, again, as you know, reported in the United States, India, Brazil, and Europe. Surprisingly, there are relatively few cases reported in Africa, as well as in Australia. And the distribution of mortality around the world is somewhat matching the distribution of total cases, again, sparing Africa and Australia. This is the distribution of arboviruses around the world. over the past 5 decades, there has been an unprecedented increase or emergence and re-emergence of epidemic arboviruses. And if you zoom on in India, there are 3 out of the 5 endemic arbovirus reported that are co-circulating in India. The 5 arboviruses recognized so far are Zika, Chikungunya, Dengue, yellow fever, and West Nile virus. So yellow fever and West Nile virus are not circulating in India, but the other 3 are prevalent there. Now, this increase in cases of arboviral diseases are believed to be a result of the triad of modernization, urbanization, as well as international travel. There are also reports with arthropod adaptation increasingly to urban environments. Arbovirus diseases are maintained in nature through transmission between susceptible vertebrate hosts by hematophagous arthropods, primarily Aedes aegypti and Aedes albopictus. Sorry. The enzootic cycles are restricted to the interplay between mosquitoes and the maintenance hosts, primarily non-human primates such as baboon, other green monkeys, as well as small mammals, predominantly rodents and bats. The following step is the infection overflows to humans, and this initially happens in forests and then is amplified in urban areas. This diagram just illustrates the enzootic cycle on the left side and the overflow to human leading to epidemic on the right side. The co-occurrence of COVID-19 and arbovirus epidemics is a great concern, and it is a challenge from an epidemiological point of view. The areas of overlap include large tropical and subtropical regions where arboviral diseases such as chikungunya, dengue, and Zika are very frequent. These regions have been or have lower vaccination rates, increasing the burden of COVID-19 in those areas. And it is also believed that COVID-19 pandemic hindered efforts to control mosquitoes, increasing the risk of arboviral diseases. So I'm just going to spend the next few minutes on just a quick description of the emergence and the spread of the 3 arboviral diseases that are endemic in India. So starting out with the Zika virus, it is a flavivirus that was initially isolated from monkeys in the Zika forest in Uganda in 1947. The first human case was reported in Tanzania in 1952. Since then, there have been sporadic cases in tropical Africa, Southeast Asia, the Pacific Islands, followed by a very large outbreak in 2015 that gained international attention in Brazil. The Chikungunya virus is the alpha virus that belongs to the Togaviridae family. It was initially identified in Tanzania in 1952, followed by occasional outbreaks in Africa and Asia. For the first 15 years, there were just occasional outbreaks, but since 2004, the virus spread rapidly in Asia and Africa, with the first outbreak reported in Europe, actually in Italy in 2007, and has since spread to other countries in Europe, Southern Europe, and such as France and Spain. In 2013, the first outbreak of chikungunya occurred in the Americas, in the Caribbean, and since then it has spread throughout Central and South America. The dengue virus is a flavivirus with 4 serotypes, dengue 1, 2, 3, and 4, that can all co-circulate. The first epidemic of a clinical dengue-like illness occurred in China in 1780, though the first virologically proven outbreak was in Kolkata in 1963. Since then, the virus spread to Africa, Southeast Asia, Americas, and Europe. And over the last decade, there has been a dramatic increase in cases, up to 8 times increase in cases reported to the WHO. At this point, half of the world's population is considered to be at risk for dengue. One of the biggest challenge regarding the intersection between COVID and arbovirus epidemics is actually making the accurate diagnosis of the infected patient. And this is primarily due to an overlap of clinical symptoms as well as laboratory parameters. There is also a theoretical concern about the impact of steroids, which are one of the main treatments used in COVID, on the prognosis of arboviral diseases and the viral load. And I will later on touch on the cross-reactivity reports between antibodies of COVID and dengue, as well as antigenic similarities reported between the two diseases. So dengue is the most common arboviral disease. More than 2.5 billion people live in areas where dengue is endemic and are at risk of dengue transmission. The WHO estimates that 50 to 100 million infections occur yearly, with 500,000 cases of dengue hemorrhagic fever and 22,000 deaths, mostly occurring in children. Dengue outbreaks are more likely because of COVID-19, and they're placing significant pressure on already strained health systems in many developing countries. So this slide illustrates the overlap in clinical presentation between the 3 arboviruses and COVID. Again, most of them will have non-specific clinical presentations with fever, myalgias, and headaches, as you can see in all 4 of them. Clinical manifestations on the skin, such as petechias and rash, are also very common in all 4 diseases. They have been reported with COVID, initially from reports in Italy and then Spain, and they can pose a challenge as are considered to be caused by arboviruses. 1 in 4 people infected with dengue will actually get sick. Majority will have asymptomatic infection. From the ones that have symptomatic infection, some will have an undifferentiated type of viral syndrome. Others will have dengue fever with or without hemorrhage, and only less than 5% will present with dengue hemorrhagic fever with plasma leakage syndrome and plus minus shock. The mortality is very high, up to 50% if not treated.
Dr. Ziana, your microphone is on the desk. Can you get it to your mouth? Because there is a scratch noise it is picking up from the desk.
I'm not sure it's a laptop microphone, but the scratchy noise could also be my cold, and I just have a scratchy throat. So
okay.
Yeah, probably the combination, but
thank you.
Okay, you can keep going.
Okay, continue.
Can you understand what I'm saying?
Yeah, we can keep going. Keep going.
All right, so this slide is just depicting the overlapping immunological cascade and the shared pathophysiology between dengue, hemorrhagic fever, and COVID. So both diseases cause activation of the immune cells, leading to a Th1 pro-inflammatory response, primarily driven by pro-inflammatory cytokines such as TNF and IL-6. The dengue virus can also cause direct destruction of the platelets in the periphery, as well as bone marrow suppression, leading to reduced megakaryopoiesis and leading to thrombocytopenia. Similarly, the COVID virus can cause endothelial damage, apoptosis of the platelets, and also lead to thrombocytopenia. Both diseases share a coagulopathy, dengue typically more with propensity to severe bleeding and DIC, Patients with COVID tend to have a hypercoagulable state with venous as well as arterial thrombosis. And we touched about all that, perhaps just to mention that pro-inflammatory cytokines also are responsible for the acute worsening of COVID-19, typically seen a week after the onset of symptoms, something that has been described as a cytokine storm. These pro-inflammatory cytokines, again, are promoting this Th1 inflammatory response. And hence, the role of IL-6 inhibitors, such as tocilizumab and sarilumab, as well as Janus kinase inhibitors, such as baricitinib, in the treatment of cytokine storm in the setting of COVID-19. The role of antibody-dependent enhancement, or ADE, in the disease progression has been reported in numerous viral diseases. It is believed to be caused by the cross-linking of virus and antibody, or virus and activated complement, with interaction with cellular molecules that all promote internalization of the virus and increase the infection in monocytes and granulocytic cells. And the dengue is probably the best disease model to demonstrate this antibody dependent enhancement. So what happens with dengue is that after a homotypic infection, one is immune, and homotypic infection would confer long-lasting immunity for infection with the same serotype. But the cross-neutralizing antibodies against reinfection with different serotypes are short-term, and there are many non-neutralizing antibodies. So these heterotypic antibodies may trigger an enhanced reaction and are associated with higher odds of severe forms in the setting of a secondary infection with a different serotype. That has also been observed in children, young children that have passive transfer of immunoglobulins and antibodies from their mothers, and tend to have a more severe form of dengue. Primary. Antibody-dependent enhancement also plays a role in the development of the dengue vaccine, and is illustrated in the story with Dengue Vaccine, which is a live recombinant tetravalent vaccine that was developed by Sanofi Pasteur. It is now approved for children above the age of 9 and adults up to 45 years old. It is quite efficacious, preventing 80% of hospitalizations and 84% of severe disease at the 5-year study follow-up. Nevertheless, what was noted in the initial trials is the increased risk of hospitalizations and severe dengue in seronegative individuals that was noticed about 30 months after the first dose. Hence, the recommendation that a pre-vaccination screening strategy should be used, and the vaccine should only be given to persons that have evidence of dengue infection by serum IgG. So I'm now going to change directions and talk about some epidemiological studies that try to explore the relation between dengue and COVID-19. So this first study was a study done in Brazil that focused on how COVID-19 has spread through Brazil. They found that the highways played a major role in the spread of COVID-19. But looking on the map, they noticed some case-free spots, and they were looking for explanations. So Nicolelis is the main author, and he noticed the following, that in areas where you had high antibodies, IgM, for dengue, there was a lower incidence of COVID-19 cases and a lower infection growth rate, as well as a lower mortality. So he concluded that there is an inverse correlation between COVID-19 and the dengue fever, and similar observations came from countries in Asia and Latin America, as well as islands in the Pacific and Indian oceans. This negative correlation between COVID was not observed with IgM to Chikungunya virus. So the authors hypothesized that the viruses could have cross-reactivity. They speculated that other viruses, other flaviviruses such as Zika and yellow fever may have the same cross-reactive immunological interaction with COVID-19, and that should be further explored. They also hypothesized, and this was before the availability of COVID vaccine, that actually a dengue infection or immunization with a dengue vaccine could be protective against COVID infection, which did not pan out. And they were speculating that this could provide solution to stop the rate of growth of COVID-19 in these areas. Now, a different study coming from Brazil that was published in CID in December 2020 looked at 2,351 participants that developed COVID from the Amazonian basin. They interviewed these patients, and 50% of them reported a previous dengue infection. These patients were there contacted by telephone during the first days, which counted as a baseline contact, and then at day 30 and at day 60, which was the end of the follow-up, after the COVID diagnosis. They were given questionnaires retrieving information about demographics, relevant comorbidities, history of dengue, and as well as other endemic infections, as well as COVID information regarding presentation, need of hospitalization, etc. So what they found is that patients with history of dengue overall had greater number of comorbidities. They were more likely to have a history of malaria, chikungunya, or leishmania. They tended to have more symptoms than patients that did not have dengue, more likely to have a chest CAT scan, and more likely to receive steroids. There was decreased mortality, which was significant up to at 60 days after the diagnosis of COVID in the patients that had a prior symptomatic dengue infection. So again, the assessment of dengue infection in this study was done by history. And this graph is illustrating in figure 1, just a Kaplan-Meier estimate of probability of death from COVID in patients according to history of dengue, and very significant p-value, 0.02. On the right side is an association between dengue and demographics, as well as treatment with mortality in a forest plot display. And you can see the hazard ratio for history of dengue below 1, showing that dengue is protective, as well as treatment with steroids, all the others on the right side. The authors concluded that the symptoms were more prominent in patients with history of dengue, most likely due to enhanced inflammatory response, due to antibody-dependent enhancement, what we discussed earlier. They compared this to be similar to severe symptoms associated with the secondary episode of dengue or primary dengue in persons who received the tetravalent vaccine Dengvaxia. The noted association between mortality and from COVID and dengue does not prove causality, but the authors concluded that dengue might induce a degree of immunological protection against SARS coronavirus 2. In agreement with these assumptions of cross-reactivity between antibodies are reports of false positive IgM and IgG for COVID-19 patients that had dengue also false positive IgM, IgG, very interesting, were found in blood samples of patients with dengue before the COVID pandemic, so before 2019, suggesting that this cross-reactivity is a real phenomenon. Inversely, 2 patients from Singapore were reported to have false positive serology for dengue, despite a negative RT-PCR for dengue, and were found to have later on have COVID-19. This serological cross-reactivity has been particularly observed when using rapid serological tests. And lastly, another study looking at interacting epidemics in the Amazonian Brazil and looking at the prior dengue infection and its association with COVID-19, published in CID in May this year. This study is very different than the other study because it was based on an analysis of blood samples from inhabitants from a small town in the Amazon before and after the first wave of the pandemic. This was a cohort of random people that was started in 2018 and had 5 assessments during this time, including blood samples. So when comparing blood samples before the COVID pandemic, 37% of the patients, individuals had anti-dengue IgG positive. Post first wave of the pandemic, 35% of these people had been exposed to COVID and had a positive IgG. Out of these patients that had a positive IgG to COVID, on questionnaires, 57% of them reported symptoms at the time of the infection. So this study's conclusion is contrary to the cross-protection hypothesis that the other 2 studies have found. They actually found no protection and are arguing that there is a syndemic or synergic interaction between the 2 epidemics, so that one is exacerbating the other, suggesting that patients that had dengue in the past are more likely to have symptoms from COVID or severe symptoms from COVID. Their explanation of the results are based on underestimated prevalence of dengue in the prior 2 studies, because the assessment of dengue infection was based on history, and this current study was assessing exposure of dengue by using antibodies, so much more precise exposure. So I think the issue remains unsolved as far as the big interaction from an epidemiological perspective between dengue and COVID. 2 studies suggesting that dengue has actually a protective effect. 1 study suggesting that actually that's not the case, and that dengue might actually have a synergic effect and increase the prevalence of symptoms with COVID. Now, asking the question, what happens if a patient gets infected with both at the same time, COVID as well as dengue? And this is a systematic review of 16 cases, was published in BMC Infectious Disease in 2021. They reviewed all the case reports of co-infection, found 16 cases in 8 countries. Most of these cases occurred in adults, 18 to 69. 1 case was reported in a 6-year-old, male to female ratio 2:1, probably just a marker of exposure to dengue, more likely to happen in males. Fever was the most common presenting symptom, followed by dyspnea, cough, headaches, and cough. Surprisingly, 2 patients actually presented with just arthralgias. I'm sorry, the screen is cutting off here for me, so I cannot see exactly. But so a small proportion of patients presenting with symptoms that are not typical for COVID. Right? Okay, anorexia was in 2 out of the 16 patients. Thrombocytopenia was the most common diagnostic finding, followed by lymphopenia, leukopenia, and elevated D-dimer. Leukocytosis in 2 out of the 16. 5 out of the 16 had ground glass opacity on chest X-ray or the CAT scan. The diagnosis of dengue was established primarily by use of rapid diagnostic tests. The diagnosis of COVID also primarily by RT-PCR in 11 cases. What is striking is the mortality rate. So 6 out of 16, I think almost 40% mortality if you get infected with both, which suggests that perhaps the last study, epidemiological study by Ferreira, was actually more accurate, and perhaps there is a syndemic relation between the two epidemics. The median days to recovery was 11 days with a range from 9 to 20. Also of interest, COVID was typically not included as a differential diagnosis in the dengue patients that presented without difficulty in breathing. And as you notice, there were 6 of them. And the COVID test was only performed when there was no improvement following treatment. This led in delayed diagnosis, non-compliance with COVID-19 prevention protocols, and there were cases of hospital-acquired COVID in these reports. This review article underscores the importance of accurate and timely diagnosis and the importance of using virus-specific tests to avoid the possibility of cross-reactivity on serology. And just as a conclusion, the control of the COVID pandemic and arboviral disease epidemics, I think lies in vaccine development. And we have made huge strides with the vaccine development, especially the new platform of mRNA vaccines, which allows for rapid, inexpensive, and very scalable manufacturing. There is a huge number of people that do not have access to vaccines. The next step is actually providing access to vaccines and providing an equitable distribution of the vaccines. This was cut off us from the emergence of events. The last one, the new kid on the block, is the Delta Plus variant that is on the rise now, has been initially reported in India, again, similar to Delta, now reported in a couple of countries, especially in England, where on the last analysis I saw, it reached about 6% of all the cases of SARS that they were able to do genomic analysis on. I think mosquito control strategies remains the main strategy for control of arboviral epidemics. Vaccine development, I think, would be great in those areas as well. There are a couple of other vaccines that are being developed for dengue. There is no vaccine development at all happening for Zika or nor for Chikungunya. So in conclusion, the COVID-19 pandemic brought numerous breakthroughs in research, care, and innovations in public health. I hope that we will be better prepared for the next emerging infectious disease. There are better surveillance programs, better response measures, and hopefully making this new mRNA platform available, which is quickly scalable and will be able to provide the number of vaccines that are needed to control this. I'm going to stop here. That's all I have. And thank you very much, and happy to take any questions.
Yeah, thank you for that comprehensive presentation. So we'll open up. People can type in the chat windows or can ask, just raise your hand. So Ram, you want to start off? You seem to be itching for to ask something. If you can unmute your microphone.
I do have a question, but not directly related. I had been aware of it, but I was wondering, what is the best speculation for such lower incidence of COVID in Africa?
Yes, that is a great question. I think that one of the reasons would be the population structure in Africa, and that's a much younger population. And some, I was just looking because somewhere here at some point I had some numbers, but I think I lost them. So let me see if I can try to remember. So the median age in Africa is very, very low, perhaps something about like 20 years. The lowest the country with the lowest age group is actually Niger, with a median age of 14. I could not believe the numbers. I was trying to write them down. Compare this with India, which is 28, America, which is about 38. Europe is around perhaps 40, even a bit higher. The highest is actually Monaco, with an age structure of 55. So I think younger people, as we know, are significantly less likely to have symptomatic COVID. There might be also a component of access to COVID testing in general, but there hasn't been any increased mortality noticed from Africa either, which makes me think that perhaps this younger structure overall in the population plays an important role. There are other elements that have been described in the literature, such as the ACE polymorphism, that apparently provides some protection, and a certain type of polymorphism is more prevalent in Africa. There is also a hypothesis that the concomitant epidemic of malaria and COVID is actually providing some protection. So patients in Africa will get malaria, and not only one episode, but multiple episodes. That would lead to antibodies against glycoprotein 1. And some of those antibodies are also recognizing COVID. And it is believed that this is one of the reasons that patients that are exposed to COVID in Africa are less likely to develop symptomatic disease. That's what I know so far.
So
it is very surprising, right? The numbers are very, very low, except South Africa, which has a different population structure, more similar to Europe, with older population.
So before I go to the questions in the chat window, let me about the African pandemic. You know, in the first wave in India, when the pandemic started all over the world, in the United States and Europe, in India the rates were quite low, and they were thinking the same thing. We are all the time exposed to infections. We are a younger population, and therefore nothing. It will never be that bad, until the second wave came, and it was as bad as it could be anywhere in the world. Likewise, now I've been talking to doctors in Mali, I talked to doctors in Ethiopia and Kenya. They're saying the numbers are rising. I think they say, firstly, they under-tested their population quite significantly because they didn't have resources. But all those countries, I think they're beginning to see fair amount of infections, and I think they have better testing capabilities now, so they're able to find it. I think I'm not so sure Africa will be protected unless we vaccinate them.
No, I completely agree, and I think it is almost tragical and astounding. I was reading some reports that 4% of the population in some developing countries have been vaccinated, only 4%. That unless we increase access to vaccines, we are never going to win this war with COVID. And when I'm saying increase access, I mean global access. In a way, one could argue if it is really ethical to provide booster shots and to large segments of populations in many developed countries and rich countries, while those shots probably would have a much more important role in developing countries that have no access to vaccine. The WHO initially said try to save those booster shots and don't approve booster shots, and let's try to help areas that have very, very low vaccination rates, 4%. Unfortunately, the WHO doesn't carry any political power, and there is no way for them to control any of the policies that are happening all around. So hence, we are just expanding our booster shots in America, and Europe is doing the same, while other countries have very, very low vaccinations.
So let me ask you, if you have both COVID and dengue at the same time, how are you going to manage steroids and low molecular weight heparin? How do you go about it? I mean, let me ask you, steroids make dengue worse?
That's a very good question. Studies have looked at the role of steroids in dengue. The last meta-analysis looked at about 13 studies that actually looked at steroids given at different phases of dengue. And in none of the phases, there was no detrimental effect of steroids on dengue. There was no increase in viral load of the dengue virus. And the biggest difference in a positive way that was on dengue was during the plasma leak phase. So patients that got steroids during that time did significantly better than without steroids. In the later phases of dengue hemorrhagic shock, it didn't seem to make a difference. And overall, there is no clear recommendation to use steroids. But I think that the conclusion of this meta-analysis was that they might help and they definitely do not harm. Now, in general, we are concerned with steroids regarding direct effects on immunity and decreasing immunity and perhaps decreasing the ability to fight viral infections. But I think in viral infections that where the immune response and this Th1 pro-inflammatory response plays such an important role in the pathophysiology, those diseases most likely would benefit from steroids rather than have a detrimental effect, especially if used later. So not at like immediate diagnosis, but just during the second phase.
So in your slide panels, you showed that the dengue will make you bleed and COVID will make you clot. So how do we go about with the low molecular weight heparin if you have to use it in COVID? If they have co-infection, how do we go about managing that?
I'm not sure what's being done on the ground. So perhaps somebody from India would tell us what the standard of care is there. In practical experience, we have very few cases in the US of dengue, and it's all imported. And I think that's a very good question. I would be very curious to know what you guys see there on the ground.
Yeah, Prem Kumar, you asked the question. You want to comment on that if your microphone is on? Yeah, go ahead. Prem, go ahead.
Yeah, good evening all of you there and good morning in India. Actually, the Ministry of Health and Family Welfare, Government of India has released guidelines regarding the management of COVID and seasonal co-infections like influenza, dengue, malaria, leptospirosis, scrub. There is a document actually in which it's mentioned that the steroids do no harm. So we can go ahead with the steroids if there is a co-infection between dengue and COVID. As far as this low molecular weight compounds, that means anticoagulants, are concerned, you should be a little cautious, and until the platelet count is below 1 lakh, you can give this anticoagulants, or if it is below, then I think you should withhold. That's what it said. That's what it said. Actually, the sharing a common pathogenesis like antibody-dependent enhancement, cytokine storm, vasculopathy, and coagulopathy in both. So cytokine storm is also detected in dengue, just like in COVID. So I think that's what is mentioned.
and steroids can be used, and low molecular weight compounds should be withheld when the platelet count is below 1 lakh. And one more difference in the management is in dengue, the fluid liberal management, and in COVID, because it's a kind of ARDS, fluid restriction strategy. So there you should be cautious, and when you are unable to differentiate between these two, fluid management, strict monitoring is required. That's what it is said. Thank you, Dr. Shelmari.
Yeah, Dr. Zena, rapid antigen test gives false positive. So in India, they use IgG and IgM for dengue. Are you recommending that to avoid that and use RT-PCR? What would you suggest where India now has fair amount of COVID and dengue is now prevalent? India and I think Pakistan and Bangladesh, they're all seeing dengue after this wave of COVID. How do you go about diagnosing them?
Right, so I think that those were isolated reports of cross reactivity and primarily on rapid serological tests. The data all from Brazil done on thousands of samples did not find that cross reactivity. Though, having said that, I think if there is an option of using RT-PCR, the problem is it's a more expensive and more selective test. That would be the better test to use, especially early in the disease. Not sure about the availability. I think it's restricted probably to large centers, the same it is in the US, and it is a more expensive test. So I think we are left with having to make the diagnosis based on clinical and serology. I think what is very important is to just rule out COVID, because that has the major implications as far as infection control. I think dengue is also important because patients that would have chikungunya, for example, the main treatment if they develop those joint pains and then chronic chikungunya would be NSAIDs, and you don't want to give that if you have dengue because of increased risk of bleeding. So you want to stay away from aspirin and NSAIDs. On the other hand, if you have chikungunya, that would be the #1 treatment, at least initially. And just one comment about chikungunya. I think that it is interesting. The COVID-19 mostly the scale of the outbreak, the symptoms, as well as the mode of transmission being aerosol or droplet. It's being compared to the 1918 influenza pandemic. But I read an interesting article where the authors were making the case that it should be actually compared to chikungunya, because this is a biphasic disease. And I think somebody mentioned long COVID before, and similarly to chikungunya, which can give you this chronic, very disabling symptoms up to 3 to 5 years after the initial infection. Long COVID can do the same. So far, we don't know for how long, but it's a significant percent of the patients that had COVID, even mild to moderate COVID. And in a way, the comparison as far as impact on economy and the disability and loss of work should be closer to chikungunya than the influenza.
Yeah, I think the point that you made that this false positive is an overestimate. I think by and large, the test is fairly reliable. That's what I think the Indonesians reported this. We're getting false positives, but it's a very small number. I think the Brazilian study had lots more patients, and they were able to reliably detect dengue in the presence of COVID. So I think the false positive is an overestimate. There will be some, but I think to switch to RT-PCR is going to be quite cumbersome to do that in India. So I think we should start with what you have, and then if you are facing these diagnostic challenges, maybe at that point you want to switch, but not change the paradigm yet. I think we don't know enough. In the United States, we would do RT-PCR, but I don't think in India you can implement that. Dr. Sudhakar, you had a question?
Yeah, I understand that the the vaccination is quite effective against dengue. So, as I understand from what she said so far, there is some cross protection also towards this COVID-19. Why is this vaccination not so advanced? It's not being followed against dengue. If we vaccinate people for dengue, perhaps we can protect them from COVID as well.
Sure, that's an interesting. I think that this topic still needs to be explored. The 3 ecological studies looking at the association between COVID and dengue, all done in Brazil, had discrepant results. 2 of them showing a protective effect. The third one, the most recent ones that actually used blood samples and serum IgG to assess exposure to dengue showed that there was no protection and actually a syndemic effect between the 2. Independent of that, I think that the vaccination against dengue should be promoted. I think that the vaccine had a bit of a hiccup initially with this discovery that it can make it can give you more severe disease if you never had dengue, and it requires screening for prior exposure before giving the vaccine. This increased mortality has primarily noticed in children, and that's why the vaccine is actually not approved in young children below the age of 9. Why the vaccine is not more used, I think it's probably also again a component of cost, availability, and perhaps the need of serological testing before giving the vaccine. Though it is fairly protective, 80% at 5 years, and I think if it would be more available, it would make a difference. I do know that Japan is now in phase 3 clinical trials with a new dengue vaccine that seems to be very, very well tolerated, very efficacious. There are a couple of other dengue vaccine candidates. So I think the future for dengue will be a vaccine that will be very effective and hopefully be able to go around this antibody enhancement, which is what has plagued this first vaccine and brought some initial bad press. I think with all these vaccines in diseases where cytokine storm and cytokine are so important, such as COVID, I think it's very important to just strike the right balance between the Th1 pro-inflammatory response versus the Th2 inflammatory inhibition, and very small differences, you have to tweak it just right. There were initially major concerns about the COVID vaccine actually leading to perhaps an antibody enhanced effect similar to what has been noticed with the dengue vaccine. It did not pan out, and the COVID vaccines are very safe. I'm talking in general, and particularly the mRNA vaccines. So I think it's probably the future in general for vaccines, and once we have a easier to use dengue vaccine, I think that it will be widely used as long as it is available. I think overall availability of vaccine is still a major issue globally. I think India is doing a fantastic part. I could not believe, I guess it's not news for you guys, but 67% of the vaccine in the whole world is coming from India. So it's really incredible. So you should have no shortage of vaccines.
Before I take the next question, let me ask the people in Vizag, how much of dengue fever are you seeing, Dr. Sudhakar or Prem Kumar? Are you hospitalizing patients for dengue right now?
Yeah, there is a regulation here in Visakhapatnam district that, all the suspected cases should send their samples to the King George's Hospital for confirmation. And we have about 40% of the test results being positive in most of the samples that we get here in KGH. So it appears 40% of the total samples that you get, in the sense that the positivity rate is almost 40% of the suspects. So that's quite high. So we had about 20% of the cases similarly in the last year at the same time. So that basically shows that the infections to the other viruses are quite high.
So, Jana, now that he set the ball rolling, 40% of people that suspect actually have, would you now recommend, at least in the district where this college or this region, that you do testing for both COVID and dengue every time you see, because the symptomatology is very similar?
Absolutely. I think 40% is very high, and testing for both, I think, would be recommended even at very low positivity rates, just because it is so important. So at 40%, no question, yeah, it should be testing for both.
Sudhakar, can I ask you? Yeah, go ahead.
I'm just curious what the positivity rate is on COVID testing.
Yeah, that's what I'm about.
Yeah. The positivity rate as of now is about 2%. It's around 2% in the same district.
Okay. So, Sudhakar, is it possible, if you take our hospital, every patient that we admit, for whatever reason, we will test them for COVID. Is that the practice in your hospital, and is it possible for you to do that?
I mean, amongst the 40% that I have told you just now, all of them are tested for the COVID as well.
Okay. And what about if a patient is admitted on the surgical service? Would you test them?
Yeah, we do.
Okay. Okay. There's another comment saying that the rainy season led to a lot of waterlogging. They just seen leptospira patients there. So I think dengue is very much going to be the problem. So they're seeing a lot of fevers now getting through scrub typhus and leptospira, so dengue just adds to the problem. I think, Zena, maybe you want to go work there instead of staying here, because it looks like they need you a lot than we do. You want to comment on that?
No, it seems a very exciting place to be as an infectious disease specialist. I agree.
Yeah. So another comment, we have a couple of patients with combined COVID-19 and dengue infection and cardiac involvement in the form of acute coronary syndrome associated with significant thrombocytopenia. That's what they saw there as it relates to both COVID and dengue. So you want to comment on that?
This seem very, very complicated cases to manage because of the need of anticoagulation, antiplatelets for the coronary syndrome, and the risk of bleeding probably needs to be patient individual decisions based on every single patient. I don't think that there is any recipe what to do with them, but the risk is very high if you do not, or if they start bleeding. So I guess it will be just very careful monitoring while giving antiplatelets for the coronary syndrome, very careful monitoring, having platelet transfusions on hand, and just supportive care during the dengue phase.
So for the acute coronary syndrome, you wouldn't have a problem if they gave aspirin or Plavix, as long as they have platelet transfusions readily available. Would that be okay with you? Would that be okay?
Yes, yeah.
Okay. Okay, somebody else raised their hand. It says Zoom user. Please go ahead and unmute and ask your question. No. Okay. I don't know who they are. The two raised hands, if you could go ahead and unmute your question and ask your questions. Ram, you have anything else to ask? Okay, all those who raised your hands, Dr. Malleshwara, go ahead, unmute your microphone and ask. Dr. Rao?
Yeah.
Go ahead.
Sir,
please.
Good morning, sir.
Good morning.
Thrombocytopenia is very common nowadays in our area, not in especially dengue and scrub. And we are getting cases with thrombocytopenia without dengue and scrub also. They present like dengue, but we tested for dengue. It is negative. The scrub also negative, and they are not possible even COVID also. We are seeing such type of cases recently.
Yeah.
Every day we are seeing at least 3 to 5 cases with very low thrombocyte count, 30,000, 40,000.
Dr. Zaina, you want to comment on that?
No, I think that again, difficult case by case management and very close follow up for the low platelets. I mean, sometimes low platelets are not necessarily translating into later bleeding, depending on the patient, depending on the exact pathophysiology of the thrombocytopenia. But there is no really no treatment other than treating the diseases that cause it. Other, supportive platelet transfusion.
Yeah. So you're saying, Dr. Rao, that they come in with thrombocytopenia and fever, or just thrombocytopenia?
No, not just thrombocytopenia. Just like dengue, they come with fever, headache, and everything. And the fall in the thrombocyte count also just like dengue. Initially, it was high. Gradually, it was coming down. Then slowly, it's going up.
And then when you look for the virus, none of them are positive for dengue or scrub or anything like that.
Yes.
So there's something else.
Does the platelet count usually improve while on doxycycline or treatment for
we give yes. For scrub types, we are giving doxycycline, but for COVID, we are not giving any antibiotic. We are giving only fluids according to the hematocrit and the blood pressure. Slowly, they will improve.
Yeah.
Okay. Dr. Prem Kumar, you want to comment on it? You raised your hand.
Yeah. I completely agree with Dr. Malleswara. For the last 2 weeks, our OPs are being flooded with cases of fever, and probably I might be seeing 10 to 15 cases in a day, but Dr. Malleswara has a huge OP. He must be seeing more than 40 a day, and that is true that people are coming with fever, headache, that's also not severe, and myalgias, and COVID is negative, dengue is negative, sometimes even the scrub is also negative, and thrombocytopenia. And fevers are also not coming down within 5 days. They are lasting for 7 to 10 days. And whatever, here we little lacking in investigations. Like earlier, I sent a few samples to SWIMS Tirupati, where they detected it is H1n1 a few fevers. But on a large scale, we are unable to, do a virological surveillance. That's why we really don't know whether it's a coexisting seasonal influenza or some other virus which we are unable to detect. But this is happening. All the tests are negative, and fever is a little prolonged with thrombocytopenia, and I think it's coming on its own. We are keeping doxycycline, and I am trying, oseltamivir. Fevers are coming down. Really, I don't know whether it is due to oseltamivir or doxycycline, or it's resolving spontaneously. But everywhere in AP, even in Hyderabad, also a lot of hospitals are reporting prolonged fevers, prolonged viral fevers with thrombocytopenia, and coming down and resolving on their own. Right.
Dr. Zaina, you want to comment on it?
I actually just had a question. How is the influenza surveillance in India right now? So I know for us, we are not in the season. We don't haven't seen actually any influenza case the last month. And the second question is, do you guys use PCR for the diagnosis of influenza, or are you relying on the rapid antigen test, which is significantly less sensitive? So
Actually, the influenza surveillance and testing has taken a backseat, to be frank, in the emergence of COVID. And earlier, from 2009 till the emergence of COVID, every year we used to send the samples for RT-PCR, H1n1, and a few used to come positive. But now labs are, not doing H1n1 or H3n2, that's influenza surveillance. We had to send the samples to Bombay and other places where like Specialty Ranbaxy Limited or their private labs, and all the people can't afford. So initially I sent a few samples for those who can afford, and that turned out to be H3n2. So on that basis of around 10 reports, I started giving oseltamivir for these fever cases, and it's responding well. I presume it's the H3n2 seasonal influenza.
Okay. Just to briefly comment on that, I think either there's another virus there that we haven't detected it. But there are some cases that we see here which are actually anti-nuclear capsid antibodies against COVID. So this is the second coming of COVID, where the developed myositis, ITP type of syndromes, and we think it's sort of a prolonged or a long COVID syndrome. So as you're doing your workups, could you also add anti-nuclear capsid antibodies and ANAs to see if this is an autoimmune disease being triggered several weeks after they had COVID? So I think it's one line that you want to explore until we know there's a new virus as you keep working up. Dr. Naveen, I think you were able to unmute your microphone now. Do you want to ask a comment?
Yes, sir. Thank you for the opportunity, sir. Sir, regarding testing every case that is admitted, you asked, no, sir, for COVID. Initially, during the COVID peak pandemic, that protocol was there, sir. Test every case of fever for COVID, then only for the other things. So now as the COVID second wave wanes off and the epidemic seasons is picking up, and is it in its peak, sir? Epidemic seasonal fevers are in its peak now. And we don't have so much confusion in distinguishing clinically also, sir, these fevers, sir. And the dengue cases and the malaria cases are nearly straightforward in KGH, sir, and KGH medical wards. And we are not being required to test every case of fever for COVID, sir. And most of the patients are coming with dengue reports or malaria reports, sir. And clinically, we are also almost, our residents admit the cases in EMD, sir, general medicine PGs, and they are not having so much confusion, sir. And the clear cases are clear cut, sir. Dengue cases or malaria cases. Like you asked, every case that is admitted in surgical wards before surgery and gynec wards, they invariably are screening, sir. Now we are not having so much of a problem. Test every case of fever for COVID, sir. Our cases are nearly clear cut, sir. Dengue, malaria. We are able to clean. Our residents are able to very clearly identify our cases, sir. So now we are not having so much, only pneumonia cases presenting. By default, we are going for COVID test and all, sir. But these cases, I think we are clearly able to identify, and not every case is tested for COVID, sir, every case of fever.
Okay. Okay, Dr. Madhavi, you had a question. Could you unmute your microphone? And
yes.
Somebody else.
Yes.
Yeah, go ahead, Dr. Madhavi.
Yeah. Good evening to the people from the West, and good morning to all my colleagues from India. One common thing, not a common thing, but a couple of times I have had reports saying that the people in a family had fevers, long fevers. They were diagnosed, like they were considered as viral fevers only. And at the end of 10 days, they have all been seen to be tested for COVID positive. They were all COVID positive. And some of them had a moderate type of COVID. So, and the history says they're all vaccinated. So what is the explanation we could have? Like, we assume that at least vaccination prevents transmission to others. And in a family, entire members, all the members are becoming COVID positive. Could we have an explanation for it?
Dr. Ziana?
Sure. We do see a fair number of breakthrough COVID infections after completed vaccination, and we've come to the understanding that vaccination actually does not prevent infection, though it works very well and it's very efficacious in preventing hospitalizations, mortality, and severe disease. We've also come to realize that as time is increasing from the second dose, the protection from the vaccine is also waning. So the antibodies are going down, and the 5 to 6 months later, the antibodies are significantly lower and even below the cutoff that's not clearly established, but the CDC is recommending a cutoff of 200 to be protective of infection. So once you get below that cutoff, you are not protected for breakthrough infection. Majority of the breakthrough infections are mild or moderate infections. We are also monitoring our breakthrough infections in hospitalized patients, and Dr. Chirmuri has spearheaded this effort. Our rates of breakthrough in hospitalized infections over the past 2-3 weeks have ranged from 20 to 50%. So lots and lots of breakthroughs. Again, vaccination does not protect from infection. It protects from severe disease. Even that protection is not 100%. And as the time from the vaccination goes beyond 4, 5, 6 months, the protection is waning, and breakthrough infections are quite often. I think, Israel noticed that for the first time on a large scale, on a national scale, and starting boosting almost their entire population. And that brought all the cases of breakthrough infections down. I think that's the argument developing countries are using for promoting boosters because of this waning immunity after vaccine.
Yeah. And just to add 2 more comments, that most of these breakthroughs we think are Delta, which is highly transmissible. So it's not a surprise that other members of the family are getting infected. One other unusual thing that we noticed in our breakthrough is a very high viral loads in them at the time of testing. When we did the CT values, they were very low, suggesting a high viral load. So a combination of a highly transmissible variant as well as high viral load may be the reason why it's spreading in households so much. There are 3 more hands raised, and I know you want to go, but you got to if you don't mind, take a few more questions. Dr. Buchiraju, go ahead and ask your question, please. Whoever raised your hand, could you unmute and ask your question?
Yeah, I'm Dr. Buchiraju, Professor of Neurology speaking.
Yeah, go ahead.
Like previously, these days we are seeing few cases of this febrile illness with or without thrombocytopenia, with involvement of predominantly bilateral thalamic regions. Some cases have dengue positive, some are scrub, and some may be COVID. And at times, nothing was positive, as some of our colleagues have said. And quite a significant, like recently in one of our WhatsApp group, somebody from Nasrabad has seen 3 cases on the same day. So the problem is treatment. Whether we gave IV methylprednisolone or IVIG, or initially start IV methylprednisolone followed by IVIG. But in general, our experience is most of the people responded better with IV methylprednisolone. Only caution is sometimes you may have to exclude deep vein thrombosis in such cases. So sometimes we are seeing with neurological manifestations with all the 3 common present arboviral infections with COVID. Any comments from you?
So Ziana, did you catch that? So they're seeing thalamic encephalitis. Some with dengue positive, some not with dengue positive, and some with COVID positive, and some with scrub typhus. What do you want? Go ahead and comment on that, please.
I couldn't clearly understand. Is it encephalitis picture, or is it more of a stroke with evidence of thrombus on imaging study.
No.
Yeah.
Yeah, it's not a stroke. Actually, it's more like encephalomyelitis. Some patients are altered sensorial. Some have extrapyramidal features. But on scan, they have a predominantly bilateral thalamic involvement. Sometimes few patients have even more extensive involvement like cerebellar and other areas. We have seen with all the three, like dengue, scrub, and COVID, positive. Sometimes we could see with post-viral infection also. We saw one patient who was initially admitted with COVID encephalitis with some MRI changes. Later on, he was admitted with us with Korea. So he responded well with IV methylprednisolone. I just want to, because some people have done very well with IV methylprednisolone. Few people have even tried IV IG, but generally the results are not so good with IV.
Yeah.
These patients have in general LPs done. Can you share the CSF profile of these patients just to see if it's consistent with encephalitis or meningitis picture, or pleocytosis in the CSF? Or?
See, basically, we didn't do any neurovirology in the CSF. Most of the patients have CSF studies. Only mild increase in cell count and proteins. Occasional ADA is positive. Some patients have normal CSF. But in general, we didn't do any neurovirology from the CSF.
Fascinating cases. I don't have much experience. Cases of encephalitis have been described of course, with COVID frequently, and with other diseases as well, with viral illness in general. So if it is more of an encephalitis picture, that is not that unusual. An encephalitis with hemorrhages combination, I think, would make me think more on the lines of dengue or COVID. I am not sure about the role of steroid or IVIG in these cases. Very interesting.
Yeah. Somebody else has a hand raised. It says Zoom users. Go ahead and ask.
I'm Dr. Maleshwara, sir.
Yeah, go ahead.
Recently, we are not seeing any patients with fever and hypoxia. Very few patients we are seeing fever with hypoxia. And if you tested for COVID, they are negative. Few people are positive once in a week or so. They are all non-vaccinated people. So who are not getting vaccinated, they are getting high severe infection of COVID. But we are seeing rarely, once in a week. But regularly, we are seeing huge number of fevers, but they are not hypoxic. So there's a clear-cut thing that these are viral fevers or scrub or malaria. Malaria also very low, only scrub and other viral fever.
Yeah.
This is my observation.
Yeah. Just a comment about malaria. The few we seen African travelers coming to our hospital with a handful had both COVID and malaria. We saw high viral parasite loads in those malarias in some of those patients. So the total lack of malaria control programs all over the world. I think malaria will be a problem. So malaria better than us. But just be cautious that the parasite loads we saw were high. They were greater than 5%, so which requires intravenous treatment. That's just be cautious about that as you manage your malaria.
Sir, can I?
Yeah, go ahead.
Sir, that's why, sir, WHO approved the use of anti-malaria vaccine in African countries, sir. Continuation of what she said. Recently it approved, sir. And continuation of what speaker said regarding dengue vaccine, sir. A Japanese firm has been successful and has approached the government of India for co-production of dengue vaccines of late. Dengue vaccines. Yes, sir.
Yeah.
Thank you, sir. Thank you, sir.
Yeah, Sudhakar, I think we are at 10:30.
Sir, I'm Dr. Srinivas, Professor of Medicine, sir. Just one suggestion, sir.
Yeah, please go ahead. Go ahead.
So what I have found is last year when the COVID was at a high ebb, we have not seen much of dengue cases, sir. 2019 we have seen, And 2020 COVID was the actually the game changer. Throughout the year, we have seen umpteen number of cases. It is seen that the virus also will have a domination at a particular time. When the COVID is coming down in 2021, we have seen umpteen number of cases of dengue coming here. So the virus also will fight between themselves probably. So usually now we have seen a lot of cases of dengue, unprecedented increase in the number of dengue. But the COVID is at a low ebb here. Sir. Probably one is dominating the other, maybe.
But the Kasmina, do you think that they're seeing this enhanced dengue disease? Do you think that's antibody enhancement caused by the presence of COVID antibodies? You think that's happening?
Maybe, sir, maybe. But what is happening is last year, all the conducive atmospheres for the so-called mosquito feeding was present this year, last year, and prior to that. But last year we have not seen dengue. Maybe the reason is may not be the antibodies also, because the so-called vaccination started this year, not last year.
Yeah.
Yes.
Ziana?
I think that there is a possibility of interaction. It remains to be further studied. I think so far it's been mostly looked at the interaction of the effect of prior dengue on COVID. I think now that we are in the further stages with COVID, we can look at the effect of COVID on dengue. There is definitely some interaction there, and I think enhancement, antibody-dependent enhancement is a possibility. You know, the fluctuation in numbers, I mean, dengue depends so much on many other things, including climate, rain, etc. What we noticed during the COVID, at the height of the COVID outbreak, that nobody was coming to the hospitals, except the patients with COVID. I'm not sure if that was happening there with the patients with dengue, just kind of staying home, hoping that the weather is out and just not coming. We were very surprised that suddenly all our cases of even myocardial infarction, severe illnesses, they just did not show up in the hospital. I think the understanding now, looking at the mortality during that period of time, is that they just did not present to the hospital. It's not that the cardiac morbidity overall was decreased during that year. They just didn't come for care because of worries about being exposed. So perhaps there's a component of that with dengue as well, and most patients with dengue just stayed home. Not sure, but I think it's multifactorial most likely.
Dr. Srinivas, are you seeing more in numbers or are actually seeing more in severity also with dengue?
The severity is not that much, sir, because most of the cases are 90 to 95% cases are recovering on their own with the simple treatment. Only a few cases, just 1 or 2 cases have gone into dengue hemorrhagic shock, sir.
Yeah.
Yes, sir. Yes, sir. Very true, sir. Only the numbers are high, sir. Very bad cases are very few, sir.
Okay.
Very few, sir.
So maybe it's the other way around. It's actually protecting. COVID antibodies are protecting us. Maybe. Maybe they're acting like the first infection and now sort of a vaccine type of protection. But anyway, Sudhakar, I think we've gone up to 10:30. We need to wind up now.
Yeah, sure. Thank you very much, Dr. Ziana, for the wealth of information and the knowledge that you have shared. And today, your talk will be uploaded in YouTube. There's so much of information on the slide panel that you have shared. Thank you very much. And thank you for answering all the questions as well. And thank you, Sridhar, for such an excellent moderation that you have done. This is what we always expect. I think this session has been very useful practically for most of the physicians who are over here. Who have been dealing with both the dengue as well as other viral diseases. Thank you, Dr. Ram Mohan, for your expert advice and as well as your comments. And all those people who have participated, Dr. Prem and Srinivas, for contributing to the discussion.
Yeah.
And I thank each one of you for having logged in today and participated in this particular program. And we will end this meeting here, and bye-bye till the next week.
All right.
Yeah.
Yeah. Good night, all of
Just
you.
want
See you there.
to thank you, Dr. Ziana. As always, I always learn listening to you. And I really thank the colleagues in India for sharing your experience, because we're learning from you, and it'll make us go back and rethink our strategies. So this is great exchange. And thank you very much, all of you.
Dr. Ziana, thank you very much. It was
Thank
great.
you. Thank you. It's been a pleasure. Thanks.
Okay. Bye-bye.